Hello. So now we're going to talk about mood disorders, um, primarily bipolar disorder and psychotic illness, primarily schizophrenia. So I am going to share my screen with you so we can get on to that and get started. So there we go. So as I said, we are going to talk about mood stabilizers, primarily for bipolar disorder, and antipsychotics, which are used in schizophrenic disorder. I did have addiction in here, but I'm going to do that as a separate presentation. So bipolar, just to remember, it's a series of mania, hypomania, and depression. And that's the characterization of it. You can see there's a very busy slide, lots of stuff on here. Do not panic. This is nothing for you to have to memorize all of this. The thing is that there's the big three chunks of types of medications that are considered mood stabilizers. And they're anticonvulsants, lithium salts, and atypical antipsychotics. There are still the typical antipsychotics or first generation that we will talk about, although majority of time you'll now start seeing a lot more of this second generation and atypicals used. So we're going to start with lithium, and lithium works for the manic component of bipolar. And the mechanism of action is it kind of alters the sodium ion transport in nerve cells, because lithium is actually a lithium salt, they call it, even though it is a metal, but it's still an ion. And so they think that the way it interacts with that is what helps chill things out in the nervous system. It does have a narrow therapeutic range. So again, if somebody is taking lithium, they are going to have periodic lab draws to look at their levels. One important thing is that even though this is pretty narrow of a range, that's really small, like up to 1.2, majority of times is that people require like almost right at the edge of the top level to get the good effect. So as I mentioned regarding the mechanism of action, it really requires normal sodium levels. So if somebody does not have normal sodium levels, whether they've got significant weird problems with their kidneys, they shouldn't be able to take, they should not take lithium. Now, the other thing that's kind of interesting, don't know how much you know about it, is some people drink a lot of water when they've got different psychological disorders, and they can actually, have an intoxication of water. They call it water intoxication, because they just flood their body with so much water, they end up with practically no sodium left because it's just so diluted. So that's another kind of odd thing that you might find, that people can get into really big trouble with their medication, specifically lithium, becoming toxic levels because they end up with so much abnormal sodium if they do drink like 5 gallons of water every day, kind of a thing. It is, as I said, used for the manic component, but it is also used for maintenance. It's not as used as much as it used to be because of these new antipsychotic drugs, but there are a number of people that it's the only thing that works for them. And as I mentioned before, contraindication would be dehydration and a sodium imbalance, and anybody with significant renal or cardiovascular disease should not be taking that. And the reason for that is because I highlighted it here in yellow for you, is one of the serious side effects of lithium is that it can cause some cardiac dysrhythmias. So people who already have some issues with that should not be taking this. Some of the more serious or toxic side things that you'd see for toxicity, so things that you're always going to be observing for somebody on lithium, is looking for GI discomfort, tremor, confusion, sleeping. Of course, seizures, death are kind of obvious that you can see those. And then some of the other ones that you may see commonly are some drowsiness, maybe some slurred speech, some choreoathetotic movements, which is, let's say, uncoordinated, and ataxia is like an uncoordinated walk, and then hypotension. So again, regular vital signs, and you're just being able to check somebody out, and for the most part, if they seem okay, they're okay. If they're not, you got to go investigate. There are a couple of drug interactions for lithium worth mentioning: thiazide diuretics, ACE inhibitors, and NSAIDs. So the big thing with somebody with lithium is they should not be taking like Advil or whatever for their aches and pains or headaches or whatever. And I did like this photo thing I found here because it kind of brings to light that we are talking about people, not just disorders. And especially for anything that involves our emotions and mental state are very personal and painful, especially if there are problems, because people do need to take a lot of medications, and they have some serious side effects. And then there's also that whole stigma with the world. So toxicity, this is like the first time you're going to see this. Maybe the only other time you might see this is like on renal failure, or sometimes a respiratory failure, where you'd say it's acute failure, chronic failure, or acute on chronic. And that's what they have. They can have acute where they just boom, they've got really high levels, or chronic, they kind of always live a little bit higher than they should, but it's okay. And then where they always live at that high chronic, sort of mildly toxic, and then they get a bump up for whatever reason. And that would be acute on chronic. And that's just an informational point. Again, there's that narrow therapeutic range. And again, GI is usually the biggest, most common deal with problems. And again, here's what these chronic levels look like. See, it's about twice as much as what the therapeutic range is. So again, sometimes people can have that, and then they're very tremulous, they really don't walk well, they might get some sideways ticking of their eyeballs when you look at them, or they look off to the side. And then again, acute on chronic, it's just all that but worse, and neuro changes of less responsiveness. And then luckily it does dialyze out, so they do need to get dialysis as emergent treatment. And it is considered acute overdose if they have a level of 4 or higher. So now psychotics. So that's a little different. So psychotics are used, or antipsychotics, for drug-induced psychosis. Many times we have patients that are in the hospital and they're getting all sorts of things, and they're a little psychotic, just kind of cooped out from the various stimuli that they've had. They've been, comatose for a period of time. We've been giving them lots of other meds. But then there's also ones that they take illegal medications. Some people can do like PCP, heroin, who knows, whatever these other drugs are that can give you a psychotic type presentation. Also, the one that you usually would think about is schizophrenia. And but also these medications have become found to be some help in autism, as well as bipolar disorder and the extreme mania that may sometimes be inside of bipolar, Tourette's as well, and intractable hiccups. So the way these work, the antipsychotics, there's basically two groups: these phenothiazines, or typical or first generation for the most part, and then the atypicals. You don't have to get crazy on figuring all this out. This is just which receptors are blocked and all of that. But the important thing to know is that they do all address the limbic system. So it does have an impact on emotions, cognitive function, and motor function. So the typical ones are the first generations or old ones. They've been around for a really long time, about maybe 50 years or more. Well, actually, this is 2020, so I'd say 70 years or more. Um, and the first component, what type of drug it is, which is a phenothiazine, which is chlorpromazine, which is thorazine, which is the most common one that we've seen for years and decades in use. And then the other one is Haldol and Navane. They're not usually used as common as much as they used to be, again, because of all those side effects. The side effects are the same for both typical and atypical. However, the side effects are much more pronounced in the typical. They are significantly decreased, but still potential for the atypicals, but less severe than the typical ones. So these atypicals or second generations, I just pulled out 3 big chunks. These are like these little subclasses, but I just highlighted a couple of them that are the ones that you may see a lot in the hospital, like Seroquel, which is quetiapine, and Risperdal, which is risperidone. So when we do talk about side effects from these, the first one we're going to talk about is extrapyramidal symptoms. And these are really things that can also be called pseudo-Parkinsonism. And one of those things is this acute dystonia, this pain in the muscle of a tension that they have. And the other is an akathisia, which is an uncontrolled movement that they just move. You might, if you think of Michael J. Fox, you want to Google him or YouTube him, find something, and you can see the way he's moving a lot. Now, again, we think of Parkinson's as a non-moving or a slowed disease, but they do take these medications and they can get this akathisia. So that's why we call this a pseudo-Parkinsonism. And then there's also tardive dyskinesia, and that is a difficulty with moving. Usually it's almost like a tick in the neck and the shoulder, or smacking of the mouth or the lips, rolling the tongue. I've even just seen a commercial for it recently because there is a new medication out to try to help reverse some of that. The other one that's kind of important is called neuroleptic malignant syndrome, and that is not good. Usually it's that they've got too much of the medications, and it can sometimes suddenly happen. But a lot of times it's like a very, very high fever and a lead pipe rigidity that they have, and that is an emergency. And then the other usuals that are here, the anticholinergic effects. Now, the neuroendocrine things, don't just blast past that, because gynecomastia, which is the enlargement of breast tissue, is kind of distressing for men. Galactorrhea, which is milk production, both males and females that are not lactating, is a little disconcerting. And menstrual irregularities are also not very pleasant. And then seizures is there as a list, but that would be like something really, really bad, not just, oh, I have a seizure every day as my side effect. No. But also some photosensitivity can happen with some of them. If you were very interested in knowing how these different side effects are caused, is because look at all of these different neurotransmitters. All of them are hit through the antipsychotics. So I've listed just each of the different neurotransmitters, and that when they're blocked, what the result is. So I'm not going to do that. But the whole idea between an antipsychotic is really to chill them out. We used to call them tranquilizers or neuroleptics, these types of medications, but it gives them this, sense of like chilling out a little bit. This is again a little bit more, but the other thing I do want, this is specific for the atypicals, a little bit different than just the typicals, is potential new onset diabetes, weight gain, elevated cholesterol levels, and again, those others were still there before. So what's really important for people who suffer, especially with schizophrenia, is that they are hallucinating, they're paranoid, they're delusional, um, they're not having a good time. So their ability to go to work, go to school, do things, live in their home are significantly impaired. Um, so when we do have somebody that we're going to give an antipsychotic to, you do want to do a full assessment on them because there's such a variety of all the neurotransmitters that are being affected. So you want to see how they move, how smooth their movements are, their ability to talk to you, to converse, their coherence, or a small mini mental state exam, which you can do the clock drawing, count backwards, whatever. But you can first of all just know if somebody's wrong from basic interaction, that you don't have to go that far. But if you do, you could do that. But the other really big one is also similar to people with depression, is you want to address the risk for suicide. You always want to be looking into that, and see that if they have any ideations towards that. And the other thing is that make sure that they actually swallow their meds. A lot of times, because the side effects, people don't like them, or they just feel that they feel numb because they tranquilize them, sort of, they chill them out so that they're like, they don't feel that they feel their emotions anymore, so they don't like taking them. So do make sure that they are being swallowed, and that the administration times are consistent day to day. The other thing that I wanted to say about suicide risk was not about suicide risk. It was that I wanted to say about their medications, taking them, is that these people are kind of miserable. They know they're not quite enjoying life. Nothing around them is acting very pleasant when they're uncontrolled. And then they start on therapy and medications, and things start going really good. They're controlled. Their life is back on track. They're able to do things. And then, of course, they identify the fact that they're fine. And so they don't need these pills. And then they stop. And it starts all over again. And that's usually the biggest problem with schizophrenia. And that's just because we're humans. And the feeling of, I feel great, I feel perfect, I don't need to be taking this pill anymore, it's not doing anything for me, and then they just stop them. And then they can have another psychotic break, which is when they're not dealing with reality. So there is always a danger as well if you end up working in a psychiatric facility, or even just other patients that, there's a lot of people who have schizophrenia as part of their history. They take their medications and they're just fine. You would never know it. But then there are other people who are not as fortunate. They're not able to get their symptoms as controlled. They may have to take multiples or different combinations of pills. And then they may not be able to even function at a high enough level with that much on board to always have meaningful vocation. So it is a heavy, heavy lift for anybody with either bipolar, or, but more specifically, even worse, schizophrenia in their family. So do be sure to know that you're also looking always at their safety, that there's adequate lighting for getting up to the bathroom. And if you're in the hospital, call bells, all that stuff, just to be sure, because safety is the primary thing that we worry about, especially if somebody's hallucinating and they think that they can do something, or they believe they're somewhere else because they see something different. And so they're not inputting the environmental cues into their identity of reality. And then that in itself is pretty dangerous. So I believe that is all I'm going to say on this topic. And I thank you for your attention. And I look forward to seeing you back at the next time that I have another talk. I'm going to see if I can stop that. And here I am. So thank you again. And I will see you soon. Bye.